So when I was chief nurse at UHCW, I had a wonderful lead called Judith, who did some fantastic work in relation to safer staffing in our organisation, and she was my right-hand person in relation to this, and whatever she said was gospel for me. But I have subsequently found out that Judith was actually part of a trio across the country, along with Anne Casey, of people who really deeply understood the development of things like the SNCT development, and also worked within their organisations. And I am absolutely delighted that one of those people is here today, Christine Bryer, who's the senior workforce nurse at Sheffield Teaching Hospital, and one of the architects, really, of the original programme in our SNC. So there's no better people in the audience today to tell you about some of the principles in relation to setting establishments than my dear friend and colleague, Christine. So if you can give her a warm welcome to the stage. Thank you.
I'm conscious there's some people hovering outside. Should we let them in before I start? No. Nobody's coming to join us. Okay, well, good morning, everybody. As Mark said, I'm Chris Bryer. I work at Sheffield Teaching Hospitals. I am flexibly retired. I have been flexibly retired for the last 6 years. I can't get out of it. And I'm also working part-time with Anne at NHS Improvement. My responsibilities in Sheffield are with the Safe Nursing Care tool and reporting on safe staffing. I have that pleasure every month of compiling the report for the chief nurse. So I'm just going to go through a little bit of the background in terms of safe staffing and where we've come from. There's been a lot of scrutiny around staffing over the past few years, most notably from Francis. Then we had the Keogh report looking at the mortality rates in 10 hospitals, and we had the Bryer review in terms of looking at patient safety, all of which identified issues around the workforce. 2013 saw the first National Quality Board publication with 10 expectations in terms of how to get the right staff with the right skills in the right place at the right time. Then we had the government response in terms of the hard truth document. Got an echo. Thank you. And subsequently, NICE published 2 safe staffing guides for adult inpatients and maternity services. 2016 saw the refresh of the NQB guidance, and then in 2017, as Mark indicated, we had the specialty-specific improvement resource guides. And then last October, Developing Workforce Safeguard was published. Just a little bit about the approaches to establishment setting. And for those of you that have been around long enough, I'm sure you'll recognise the Telford method, which was what I became aware of when I was first charged with setting an establishment. And one of my first matrons, and we were called matrons at the time, it wasn't chief nurse, it was matron, taught me through how to set an establishment using professional judgment. And that consisted of determining the numbers of staff you wanted on a shift, multiply it by the number of hours in the shift, by the number of days, and then divide it by 37.5 to give you the whole time equivalence. On top of that, you had an uplift to provide your headroom to cover things like annual leave, sickness, maternity leave, etc. Then we have the nurse to bed ratios, which again, quite a crude method to determine how many nurses you needed on a ward. Neither of them actually told you about the acuity dependence of the patient. They didn't tell you about the ward environment, whether there were any factors that you needed to consider. We in Sheffield had a system called GRASP thrust upon us. And I don't know if anybody around the room remembers GRASP, but that relied on you having an up-to-date care plan for each of your patients in the ward area. You sat, the last thing you did before you went off shift is to calculate what needs those patients have for the following day. And then hopefully you would be able to, or the matron would redeploy staff accordingly. It never worked because we didn't have the technology to support us. It was all done on paper, and again, there was a fair bit of subjectivity applied to those assessments. In Sheffield, we became a beta test site for the introduction of the Safe Nursing Care tool in 2006, and we've used that ever since. Just going on to the diagram that Mark referred to earlier. Although nursing and midwifery has evidence-based tools available to them, they do focus on inpatient areas. And in the document, we are supposed to look at all clinical areas to establish their areas effectively on an annual basis. Within Sheffield, although we focus on inpatient areas, we have looked at other areas. We've just done a review in radiology in terms of the nursing workforce in radiology, because we are a split site. We have 2 departments, one on either campus, and there isn't an evidence-based tool for radiology nursing, but it didn't stop us. We did an activity follow, looking at what tasks were undertaken by what grade of staff, how much time that took them, and that helped us determine whether we got an appropriate skill mix and sufficient resource available to us to cover all the sessions that the department undertook. Interestingly, what I found a bit strange is that we had 2 groups of support staff in the department, one managed by the radiographers and one managed by nursing. And when I asked the silly questions, because when you don't know the area, you can ask the silly question, I said, well, what did they do differently? Well, I don't know. I don't think there is anything they do differently. One of the recommendations from that, what they actually look at, combining that workforce to improve the nursing resource that we have available to them. The principles of safe staffing identified within the developing workforce safeguards recommend the use of evidence-based tools where these are available, and that with professional judgment and patient outcomes inform the safe staffing agenda. This is one of the recommendations in the document, but it also recognises the need for a consistent approach across all areas, not just nursing, not just inpatients, and we look at all clinical staff. The board should be provided with a monthly report that advises on staffing, skill mix, care hours per patient day, and other quality metrics, patient and staff. So we look at falls, pressure ulcers, we look at staff thickness, and how much temporary staff we're using. Recommendation 9 states that nursing establishments must be assessed twice a year using the tool that is available, and the report is provided to the board. And as Mark identified earlier, where we've got new roles, we should do a full quality impact assessment. We're just introducing our trainee nursing associates, and that was one of the questions I asked of the group a couple of weeks ago, have we done it? And I just got a bit of a blank look, and then I sent them the documentation that they really should have filled in before we started, but we're getting there. So we report twice a year on our assessments of acuity and dependency using the Safe Nursing Care tool. We've also introduced Birth Rate Plus within our organisation, and I helped support the midwifery director to implement that. And that's proved quite interesting. So although the reports are done separately, they do go to the board at the same time. When we look at the results of the assessments, that's then used to, alongside the establishment setting process, to inform any changes that may need to be made to the nursing establishments. Factors related to activity, any seasonal changes, changes to patient pathways, and things like retention, recruitment, the use of temporary staff, with the outcomes are important to consider at the same time, because they may well influence any decisions that you may need to make in terms of changing your establishments. So just moving on to the Safer Nursing Care tool. How many in the room actually use the Safer Nursing Care tool? Can I just take a quick straw poll? Quite a few of you. So you do require a licence to be able to use the tool. That's managed by Imperial Innovations on behalf of the Shelford Group. And it's important for you to have that licence, because that makes sure you get an up-to-date version of the tool with the correct multipliers. We undertake assessments using the decision matrix within the tool twice a year in January and June for 20 days. We have a maximum of 3 nurses per ward, senior nurses, who are trained in the use of the tool. And every week, those results are validated by an external person, and that could be a clinical educator, it could be a matron, or another senior nurse, but from another area. We've just in our February, we delayed our data collection this year to February, because January is always a bit trying, especially after Christmas, and we've got surge wards open, so we delayed it until February. And I naively thought that everybody was using the Safer Nursing Care tool, and I got a bit of a shock when one of the validators rang me and said, are we using the critical care minimum data set? I said, what for? She said, to determine dependency. I said, no, we're not. But one of our areas had been trying to use that alongside the Safe Nursing Care tool, and they'd overinflated their assessment. So we had to do a little bit of retraining. It's important that you have your trained personnel undertaking the assessment, as well as your validators, because we need a reliable set of data to be able to really inform what your staffing requirements are. And you must have a minimum of 2 data sets before you make any changes to an establishment. We use 3, but the minimum is 2. One of the other things that we're working on in Sheffield is to try and develop an electronic solution to capture patients who require enhanced care, because currently the tool doesn't assess the needs of those patients, because in theory the needs of those patients aren't predictable. You cannot say that we're getting somebody in tomorrow, or that patient's going to be fine post-op, so they won't need any specialing. The Safe Nursing Care tool is undergoing a review and refresh at the moment, and we are looking at capturing data on those groups of patients so that we can make sure that the tool is fit for purpose and it will capture the needs of that group. It's also important to remember that the tool itself looks at things like throughput, It looks at escorts, it looks at management time, any supervisory time, and there is an uplift already built into the tool for your headroom allowance. That's set as a minimum of 22%. And you shouldn't be making any addition, because actually that will give you either an over-inflated establishment or it won't give you enough. We have our uplift set at 24.3%. We had a bit of a scientific way of trying to calculate that in terms of the split. So we have 15.3% for annual leave, 4% sickness, which is the national target, and it's our local trust target. We have 2% for parenting leave. We have 2.5% for training, and then we have 0.5% for any other carers' compassionate leave. One of the things that we've recognised is that not all areas need the same amount of time for training. Some areas need more, and I'm particularly thinking about EDs. Their training needs in terms of what they have to go through is substantially more than care of the elderly ward group of staff. It's also important to have an agreed policy or standard operating procedure outlining the process for reviewing and updating, resetting establishments. That should outline the roles and responsibilities of all the stakeholders that are involved in setting establishments, so from the ward manager right through to the chief nurse. Within the Workforce Safeguards document, there is a checklist in Appendix 6, which is there for the directors of nursing to assess their compliance with the use of the tool. I thought we were compliant until I went through it. We did our gap analysis when the document came out, and we weren't quite as good as we thought we were. So, for example, we did validate. We did have people going out and validating the results, but we didn't have a rota. We do now. And we've had to put some additional training sessions on, because what you tend to forget is that you've used the tool for quite some time, but you forget you've had new people coming in. And unless you train your new band 7s and your band 6s in terms of how to use the tool, then they're likely to make it up. They do tend to sort of over-egg it. And I think having gone out into other organisations to see how they're using the tool, one of the additions that we saw when we went and did an external visit was a chap sat out of bed, having a cup of tea, doing the crossword in his newspaper, and he'd got a monitor sat on his locker, and I took the description of his care needs from the nurse in charge, and when we got back to the classroom, I said, right, what do we score that gentleman? He's a 1A. Well, why? Because he's got a monitor on. And within that organisation, they'd made the decision that if a patient had a monitor on, then they were automatically a level 1A. He wasn't, he was a 0, because he was actually going home that day. So finally, within Sheffield, we use the Safe Nursing Care tool to determine our acute independency needs. We identify any gaps and surpluses for all inpatient areas. That's acute adult inpatients, and then we have the birth rate plus results reported separately. The results of the assessment are triangulated with professional judgment and care outpatient day. And by professional judgment, I don't mean necessarily the numbers of nurses that you need to provide care. We also look at things like the environment. We have a wide range of wards, from Nightingale-type wards to wards that have got 50% cubicles. And you tend to forget that although the care needs of the patients might be the same, the staff you need to provide that, considering the geography, might be increased, because you'll need increased people to fetch and carry and run. Overall, our skill mix is 69% RNs to 31% care support workers. Our chief nurse that was, Hilary Chapman, did try and make it so that we had an average of 70-30. It slipped slightly, but that does cover things like critical care areas as well. So there is a variation. But we're also bear in mind the recommendation from the RCN in 2010 that suggested that 65% RNs was a minimum. Our quality metrics are patient falls, pressure ulcers, medication incidents, complaints, infection rates and the percentage of harm-free care. And with staff, it's things like vacancy rates, how much temporary staffing we use and what our unavailability is. So basically we do report on those wards that are above our 24.3% and then put some rationale as to why that's the case. Our establishments are reviewed annually to ensure that they're aligned with the budgets and the roster templates, and it's amazing just how much variance we had when we started the process, because people hadn't factored into that 12-hour shifts, you can get more for your money if you've got 12-hour shifts. And we had a couple of, we've still got one ward that only work standard shifts, and they can't understand why they can't have as many staff as the ward next door. The budget doesn't stretch that far, so they need to sort of change their thinking a little bit. We consider the safer nursing care results annually, and as I said, we recommend changes to establishments when we've got 2 data sets, and that process happens in line with our business planning cycle. So going forward, we recognise that reporting, whilst it's on nursing at this moment in time, it should cover all areas and departments and clinical services. Thank you.